Thank you, Kieran. That was a terrific paper, and I'm going to take a much more pragmatic and less interesting approach to this question briefly of the fit professional. I did have the opportunity to sit next to Kieran at dinner last night and to talk with him about his research and some of his ideas, and it struck me that, in fact, for a regulator, actually, there are probably two questions that should be being asked after I talked with him. And it's interesting what just the change in a single word brings when we think about the issues that Kieran has talked about in terms of context and environment. So I am going to talk from the perspective of a regulator. And this is the Medical Council's purpose. This is the purpose of the Act that we function under. And you will clearly see that that talks about the health and safety of the members of the public by providing mechanisms to ensure that doctors are fit and competent to practice. Now, to a regulator, fit means competent and fit to practice. And I think a lot of what Kieran talked about is probably what a regulator might consider competence. Fitness to practice has come to have some more specific meanings, and most of them are around health and ability to practice. Now, I'm going to talk in a minute, or I'm going to bring up a specific issue around fitness to practice from a regulator's perspective that I hope that you can think of, and I hope you can think of those two questions that I put up, but also the wonderful picture that Kieran painted of the importance of context and the importance of the whole system of that doctors practice in. It is clear that fit doctors, and I'm using this now in the sense of healthy doctors make less mistakes. Doctors who are burnt out, doctors who are depressed make more mistakes. So fitness to practice is a huge issue for the health system. It is a huge issue in terms of quality and of safety and of cost. And it's something that I think that we need to have some very clear thoughts about. Now, the issue I'm going to bring up has already been brought up today, and I'm glad that it was. And I want to bring up the question of the ageing doctor, and looking at me, you might not be surprised that this is of particular interest. And I think it's important, and not just because of the kind of work that André Jacques has done in Quebec that Ian talked about, and that is the very old doctors, but you'll see that this is the New Zealand workforce, our figures from last year, and you can see if we start from 1980 and then we move across to the right, the peak moves. The workforce is ageing. There is no doubt about that. Our workforce in New Zealand is ageing, and I understand that in Australia it is no different. So 20% in the next 20 years above 65. One of the things that is important in considering the issues with the ageing doctor is that there aren't any necessarily individual rules. Individual differences exist. It's one of several factors in a doctor's fitness to practice. And some things with doctors may improve with age, particularly that kind of thinking that goes from experience, the formation of schemas, and the ability to apply those schemas to situations that people have seen before. However, it's clearly a risk factor. Older doctors are very overrepresentative in referrals for competence. I was recently at a conference in London, a meeting in London. Alistair Scotland from the NCAS that Sir Liam Donaldson referred to before presented some data that showed that clearly age was an extremely important factor with referrals over competence and fitness to practice. Cognitive performance, adaptability, and psychomotor skill decrease with age. Increasing patient complexity, time demands, etc., increase the problems. Now, I won't go into this, I haven't got time, but this is a diagram that's meant to point out the systemic nature of assessment of fitness to practice when we come to talking about older doctors. And you'll see that there are physician, patient, and practice factors. What is stunningly absent from this diagram, now that we've heard Kieran, is the whole context of social context and culture of medical practice. So here are some questions, some issues. Older doctors are valuable to our medical workforce. Colleges may need to identify differing support and new roles for doctors, and I hear in several instances this happening, but it's important. What does a surgeon do when they can no longer operate? And I think it behoves us as a profession to think about how we're going to use these doctors in our workforce. The overall risk is clear but not generalisable, and older physicians may require different kinds of ongoing learning structured for them. So I raise this question of the older doctor in terms of the fitness to practice and the fit professional.